next, right?
Yeah, let's do it.
Yeah, let's do it.
Okay, so I think this is coming from the last Chief Fellows, these topics, and next year they will be different. So they wanted me to present something about basics of percutaneous coronary interventions. And I did go over this in the beginning of the year, the indications of PCI. Mainly we know there's stable angina with ongoing chest pain, anginal equivalents. This group anginal equivalents is pretty much used by a lot of people outside of Massachusetts for doing PCIs, and then non-STEMIs and acute MI. And then people have been putting in stents for asymptomatic patients if there's ischemia as well. And a good example of these are the ones like going for liver transplant or kidney transplants or some form of transplants. Then there are also these indications are there in most of the cardiologist's mind, but the real indications that are inside the head of a interventional cardiologist are a little bit different. And sometimes you see this on the floor, that why is the interventionalist not putting in stent in this person when there's indication. So we really think about the feasibility and the success of the procedure. So the number one thing that is important for us is if the technically it's a difficult lesion, we'll not go ahead and do that. I just had a patient yesterday. She has very small left main coronary artery, and the plaque was extending. It was severely calcified plaque, was extending from the ostial LAD into the left main and was involving the distal left main. And the size of the vessel was at least a 6 millimeter size. We do not have a stent of that size. So it's technically difficult to do that. And also in a small left main coronary artery, you cannot, you can put a stent up to, you have to put the stent up to the ostium of the left main, then you're going to jail the left circumflex artery. So it becomes difficult. Recently had a patient who I couldn't put a stent in because the vessel, the MI or ACS happened because of a small diagonal artery, which was less than 2 millimeter in size. The smallest stent we have is 2 millimeter in size. So the arteries which are 1.5 millimeter, yeah, you can balloon them, but you cannot put in a stent in them. Then the cabbage is a totally different beast. Patients who had cabbage before, it's like they got their chance. That's how we think about them. They got their chance. Really doing PCIs or doing anything after the cabbages happened doesn't really improve much of a mortality. And it's probably because they are sick to begin with, and their baseline disease is so much that you opening up an artery will not really take away the distal disease or the small vessel disease. So diffusely diseased saphenous venous grafts, opening them up, yeah, you can open them up, but they're not going to last too long. And there are different risk scores for that, which are more advanced. And then other coronary anatomy, I gave you a couple of examples of coronary anatomy. If there are too many branches at the same point, if there's too much calcification, too much angulation, difficult to navigate the coronary because of the tortuosity. These are some of the other examples where there are relative contraindication. Now, somebody really skilled can still do it, but sometimes it's not safe to do it. And that's why we consider heart team discussion in those patients, where a surgeon can probably do much better job than an interventionalist. And we have many examples of that. So the other thing to consider, and we forget this as we become interventionalists, is the medication aspect of the procedures. So screening every patient is extremely important, and somehow over the years, because we are on a go mandate, that we forget this kind of stuff, especially the anticoagulation and antiplatelet stuff. So the contraindications or relative contraindication, I would say, because some people still do the procedure, is that if your INR is above 2, um, it will be difficult to do the procedure, especially if going femoral access. As you can see, the 1.8 for the femoral access and 2.2 for the radial access is kind of the thresholds that are recommended. We obtain these values in all the patients who are at high bleeding risk. And the other thing to think about is the platelet count. We have started seeing more and more patients of low platelet levels. So at the moment, 20 is kind of a cutoff. And if the patient is at high risk of bleeding, we want to have like 50 as the cutoff. And if you're putting an impeller or something, I would like the patient to have at least 100 of platelets. But clotting is almost normalized around 20 to 50 thousand of platelets in the body. Any questions? Any practical?
No, we're good.
If you have any practical questions, let me know. So the things that we use in the catheterization, I just want to go over some of the terminologies because they might be different. You might not be aware of it, so just want to go over them. So one of the big technologies that came into being, brought by Andrea Gerdzing, was this balloon catheter. So initially, what he did was that he put a balloon and inflated that balloon and opened the artery. That was a big deal. Now, people have done that before in the non-coronary arteries, and the pioneers were mainly the Sohn group from the California, or the Judkins group from Emory. They were mainly interventional radiologists, and the cardiologists kind of snatched that stuff from them after Andrea Gerdzing brought this technology. But the terminologies we use for the balloon catheters are one of them is rapid exchange, RX. What this technology is that you can have a wire go through. I'm just going to show you. So this is the catheter, balloon catheter. The balloon is somewhere here. Okay. So we put a wire through this, and the wire comes out of here instead of coming out from here. This is a newer technology called RX, or rapid exchange technology. The older technology was that you had a hole here, the balloon here, and then there was a hole here at the end. And then you have a inflation port where you can balloon it up, and the wire would come out of here. Okay. So this is called over the wire technology, over the wire. So you will see these terminologies used, and they are now used for different devices as well. So like TAVR is the over the wire technology, because your wire is going from here, coming out the other end, while the rapid exchange is going from here and here. So catheters, many type of new technology will be using RX technology. Now, they both have their own advantages. RX requires shorter wires. So short wires, which mean we can use a wire of 150 or 180 centimeter in length. This will require a longer wire, and it takes time. 260 centimeter exchange length wire, where your wire needs to be at least double the size of this catheter, so that when you're getting it out, your wire is still inside in the body. It takes time. Time is another issue, and then sometimes you lose the wire while pulling it out. So so these technologies are rapid and over the wire technologies. Okay. Go back. Okay. Were you able to see my drawing, wonderful drawing?
Yeah.
Yeah, okay.
Yeah.
Okay, so what is a balloon? And balloon is made up of various forms of polymers. And you know, I can go into the details of that, what kind of polymers are that. But for basics, you really need to know that there are two type of balloons. One is a compliant balloon, and one is a non-compliant balloon. And when we are describing a balloon, we are describing this length. You're seeing the length with the marker to marker. But if you see, the balloon does extend a little bit beyond that, beyond this marker, as you can see. And this area, as you can see, this angle helps it to wedge into a lesion. Sometimes a lesion is difficult to get in. So you can get this balloon in and inflate. It will still, it's like a fulcrum or a chisel that will work. And then there are kind of two tubes going inside this shaft. One is through which the contrast goes into the balloon, and one is this wire uh, shaft. Balloons can go down to 1.0 millimeter in size. We have that available, called Sapphire balloon, and I have no conflicts of interest. Just mentioning that, so that you guys know. In the cases where we have two type of balloons, like shorter balloon, longer balloon. Usually the balloons are marked with two markers, the 90 centimeter mark and the 100 centimeter. Most of the guides we use are 100 centimeter in size, so you can safely advance the balloon up to the 100 centimeter mark without looking under the fluoroscopy. And I was mentioning about the polymers. These are the different polymers. If you want to learn some chemistry here: polyolefin copolymer, PBEX polymer, polyethylene polymer, nylon, and then PET. So as you move from this POC to PET, they become less compliant, which means is that if you put a pressure with the end deflator on it, it's not going to expand too much. It's going to stay at that. So a 2.5 balloon, a non-compliant balloon, if you put a 12 atmospheric pressure, it will be 2.5. If you put 18 atmosphere, it will be 2.6. While a compliant balloon, if you put a atmospheric pressure of 18 atmosphere, and it's a 2.5 balloon, it will not be 2.5. It will become something like 2.8. So the degree of increase is much higher. Okay. And then the other point that I wanted to make.
So can I ask a question?
Mm-hmm. Please.
This is too loud.
Well, there is somebody who's not mute. Yeah.
Okay, maybe I can talk.
Yeah, you can talk. Yeah, now he's mute. You can, or she's mute. You can talk now. Hello?
Okay, can you hear me?
Yeah, I can hear you.
Okay, that's good. Saying the compliant and non-compliant balloons, is that the same thing as cutting and non-cutting balloons?
No,
or
they are different.
That's a different thing. Okay.
Yes, and I will go over those too. So the nominal pressure, you might have seen that there's when the balloon comes out, it comes with a list of pressures. And the nominal pressure is the pressure at which the balloon is at its listed size outside the body. Now you have to remember, so what is happening inside the body? Inside the body, there's pressure from the vessel wall, and could be calcium or something like that, or could be plaque. So the nominal pressure does not mean inside the vessel it will achieve the same size. It will achieve smaller size than what the size is listed. So if a 2.5 balloon is in there, it will not be a 2.5 balloon when you are going up to the nominal pressure. And other thing that it's marked on that is the rated burst pressure, which is the highest pressure at which 99.5% of the balloons will not rupture. Okay, but 0.5% balloons will rupture. And you will see some of us going up higher than the burst pressure. Usually the burst pressure is around 18 atmosphere or 20 atmosphere. Okay, so as you can see, there's atmospheric pressure below in this graph on the x-axis, and 6, 8, 10, 12, going to 22, and the balloon diameter over on the left side. As you can see, the compliant balloon, the red line, it becomes much larger when your pressure is going up, while the non-compliant 3.0 balloon, it kind of stays in a similar range. It doesn't expand that much. Okay. So we use compliant balloons usually for pre-dilation when we are dilating stenosis, because this also gives us an idea if the stenosis is not going to open. If it's not going to open, this means it is stiff or there is calcium. So we might need to do rotablation or some form of atherectomy. And then once we achieve some size with a stent, the post-dilation is usually done with a NC balloon. And you don't want to have the NC balloon go, the balloon used after this get too larger in size. So that's why we use the NC balloon. The other good thing is it stays at the same size and uniformly. The non-compliant balloon will become something like this. Let me show you what I'm talking about. Here. So the non-compliant, so let's say this is the stent. Okay. So it's not expanded fully in the middle. So you put a non-compliant balloon in here. Non-compliant balloon here. So it's going to stay like this. It will maintain its shape. So you make it larger, so it will become something like this. Okay. While on the other end, if you put a non-compliant, compliant balloon, it will still make the same shape as this. The balloon inside that of the stent is a compliant balloon. It acts more like a compliant balloon. So that's why the stent does not open up as it should. Sometimes if the lesion is very tough. Okay, so you want to use an NC balloon after for post dilation. So NC, post dil, you're going to learn these short forms, post dilation or post dil, and compliant for pre dil. Okay, go back. Now, the current balloon options that we have available is Abbott Vascular. They have these names, these brand names, Trek, which goes down to 2.25, goes up to 5.0, and then Mini Trek. Then Boston Scientific have Emerge Group, Emerge Flex and Push. Push, you can push it much better. It's much stiffer shaft. And then Medtronic has Euphora and Sprinter. And Sprinter goes down to 1.25. And there's a fourth one that is Sapphire that is now goes down to 1.0. And then they have these NC Sprinter, NC Euphora, NC Emerge, NC Quantum, NC Trek. We have Emerge and Euphora groups available. So we have Boston Scientific and Medtronic available. We don't have Abbott available here. So I was talking about the radial force, the balloon growth. So the semi-compliant balloons increases in size about 10% within the working range. As you can see on this line, 2.65, 2.94, 3.0. As you start going up, it goes to like 3.27. Notice the non-compliant balloon. It doesn't, so it's 3.02 at like its nominal pressure, where it really doesn't go up. It's like going up on the second digit here. So that's what I wanted to talk about before. So Oh, I do have a picture of this. So as you can see, the compliant balloon, the non-compliant balloon will inflate like this. The compliant balloon will have an hourglass appearance in tough lesions. So I have started using actually even for pre-dilation, the non-compliant balloons if I think there's a lot of calcium in that person. Now, there's another form of balloons called cutting balloon or scoring balloons. And what the difference in these balloons is, they are fortified by wires or some form of cutting instrument on them. And angiosculp is one time of that. What is scoring? Scoring means making lines on something. So what it does is, it's a semi-compliant, it's a kind of almost close to non-compliant balloon. And when it expands, these wires, they get buried into the calcium or the plaque, and it breaks that. And you want to have a dissection so that you can put a stent in there, so that stent can expand. So we use that when this kind of balloon, when there's a lot of, when there's focal calcium, or if the balloon is slipping, what we call as melon seeding. You might have heard this term, another word, melon seeding. The balloon might slip forward, backward, or just because of the toughness or calcium in the plaque, or maybe patient is breathing. This will stay wherever it is, and it can get stuck there. So angiosculpt is made by Abbott. We have that available. And there are other form of cutting balloons like Wolverine. We have available Wolverine in our armamentarium. And it has blades on its surface. Any questions about this balloons? I'm going to go to the stents now. Okay. So then I come to the bare metal stents. So bare metal stents are kind of phasing out. Really, very rarely somebody if uses it now. And it's mainly because of the guidelines still mention bare metal stents in patients who have high risk of bleeding or are going for surgery after 1 month. Although there are a couple of trials now by Synergy group, as well as by Onyx group, which is Medtronic, that 1 month of antiplatelet therapy, dual antiplatelet therapy, and you can stop one antiplatelet, the Plavix or the ticagrelor, after 1 month and keep them on aspirin. And the risk of stent thrombosis is very, very little in those, up below 1%. So bare metal stents are kind of phasing away, especially if you're putting a large Synergy stent. Likely risk of stent thrombosis is very little. So, but in the past, we have had many cases where the bare metal stents were placed. The problem with them was they get re-stenosed. They will close up. Their warranty is shorter. The risk of having them closed within a year is about 10%, or even higher than some studies have done 20%, which is pretty high. So the Vision, Mini Vision, Veriflex, Rebel, we have Rebel available, Integrity. These are the different sizes and lengths available. Mainly for review, that's why I put these graphs in there, or tables in there. Then we have the drug-eluting stents. We have Abbott stents, which are Xience stents. We have Boston Scientific stents, which are mainly Promus and Synergy. We have the Synergy available. And then Medtronic stents, which are Resolute or Onyx, ONYX stents. The drugs are different, but we have found that everolimus is kind of a superior drug in keeping the endothelium off the stent. So the Promus and Synergy, they are all everolimus stents, but Resolute is Zotero-limus stent. And then there's something called Polymer. So the stent, I'm going to go over the structure of stent. So what a stent is, go again on my drawing. So the stent is, you might have seen stent something like this. Okay. The stent is something like this, if you see the stents, and they have links in between. Okay, and these stents are cut by laser of a slotted tube. Like there's a tube like this, and the laser cuts stuff in it and makes this kind of structure. If you look at a strut, which is, this is the strut, okay, and you make a cross section of that, okay. So this strut is metal, and it's made up of chromium, cobalt, or platinum, something like that, some kind of inert metal that does not cause inflammation in the body. Then we put a polymer on it. I should make it different color. So we put a polymer on top of it. And why do we put the polymer on it? Because this is where the drug will get absorbed. Okay. So this is the luminal side, and this is abluminal side. So a question from you all guys: which side is more important to have the drug on? Anybody?
Luminal.
So the endothelium is on this side. So I would think that as well, but then the actual issues with the endothelium, you don't want endothelium to grow on this side, because it's going to grow inside like grass between these holes. Okay, so the drug is actually more important to be here in the abluminal side, and this is what the synergy does. So synergy is the thinnest strut, and it has only drug on this side. Here it's like bare metal stent. It's bare metal, there's metal. While Onyx has drug on both sides. Now what does it do? Whenever you have drug, you have polymer there, it increases the thickness of the strut. So the strut thickness, and I'll show you the strut thickness of different stents on one of the tables, is what it does is it causes, so if this is the strut, I'm doing another cross section now, cutting in another way. I'm cutting it now like this. And this is the coronary artery. So when the blood is flowing, it's going to hit this, and there is going to be turbulence here. The bigger the strut is, this is the strut, another strut, another strut, the more the turbulence is and more risk of endothelial injury and stenosis. So that's the theory. So they said decrease the strut thickness to the minimum. Right now, the thinnest strut stent is Oriso stent. We don't have that, but I think in US it's available now. But Synergy is the smallest strut thickness that we have available at the moment. And that strut thickness is a big thing for the stent design. So you understand the biopolymer. So what does biopolymer does? As now look at here. So you have cobalt chromium. This is the metal in these. Boston Scientific is using platinum chromium, and Resolute is also using platinum chromium. It doesn't have it here. And then you have a polymer on it. Okay. Synergy has a polymer that gets absorbed over 3 months, because after 3 months, it's not really useful. The rest have durable polymers. They stay forever. There's a 4th generation stent called Bioabsorbable Stents that have very big strut thickness. And that's why they cause a lot of stent thrombosis. And they have been taken off the market It was made by Abbott. But in Europe and other countries, there are many other forms which are still not available in US because the trials have not been very promising. So these three things, stent, drug, polymer, are important to think about. Okay, so this is a stent sizing guide. Maybe for interventional fellows, they can keep this. It's made by some guys from MGH. I made one, but this is much more detailed one. It has all the stents available. So see the strut thickness is here. Zion says 81 micrometers. Chromas is 81, Resolute is 81. And then you look at the Synergy, it's 74 micrometers. Alionair is, we don't have it. Oriso has 60 micrometers. And then we have covered stents where the stent, the holes between the stents are covered, mainly used for if there's a perforation or bleeding going on in those people. And these are different sizes, and the recommended size, which is from 2.25 to 3.25. And then how much we can stretch it more, 3.75, we can stretch it more like that. Then the other thing to think about this is for more interventional fellows, is when they are ballooning the stent, they have to look at where the markers of the stent are. So the markers, the stent edges are just outside the markers. So if you are blowing based on the markers, those two dots in the stent is a little bit outside of it. So you always have to think about when you are stenting something. You don't want to hang too much out of the vessel when you are doing that. And then Zions has mid marker to mid marker, which is different. So Zions is different than the rest. Easy to remember. Okay, so I was talking about this bioabsorbable stent. This is a stent. It's made up of poly-L-lactic acid. So what's the good thing about lactic acid? It gets metabolized in the body, and it has drug impregnated on the polymer. So it's sprayed over the polymer. So it's some of them have holes in it, so it gets absorbed in the holes inside these polymer. And then once this is absorbed in the body and the drug is gone in 3 months, the stent is gone. The issue was that there were a lot of stent thrombosis, so they stopped this. The FDA took it off the market in US. Okay, now balloons and stents are over. Now I'm gonna talk about the other stuff which we use, as the nurses say, they are toys that we use. One of them is intravascular ultrasound. Big technology. The only technology that has shown to decrease the target vessel, decrease in target vessel failure, or what we call TLF or TLR, like target vessel, sorry, TVF, TVR, target vessel revascularization rates. I've taken this from one of the friends, Alex, from Twitter. But what it's showing is that you are seeing an ultrasound of a vessel from inside. And this is the catheter. These are the markers. These markers, each marker is 1 millimeter in size. On the console, you can measure the lengths, the cross-sectional lengths. Okay. And this is blood. The grainy self is blood. And it's, you have to see a lot of images, at least I would say 100 to 200 images to start seeing things. Otherwise, it's like echo, The first time I looked at the echo, I was like, where's the heart? I couldn't see the heart. But then over time, you learn how to see things in there or make up things in there. So there's endothelium somewhere here, okay, as you can see. And then outside, this is what is this? What we call EEL, external elastic lamina. And then outside of this is adventitia. So we measure all the stents or the sizing of the stents either by this EEL diameter or inside the endothelium. So you see they're measuring the stent size by inside of the endothelium. I like to use something in the middle of that. So between the EEL and the endothelium, somewhere in the middle, which what I call midwall sizing. When you look at the OCT, it's much prettier, right? You can see much things in much more detail. As you can see, this endothelium, this bright thing, which is the sponge. It's actually like sponge, the endothelium. Inside of that is something like elastic fiber, which is actually media, which are muscles. And then right outside of that is the external elastic lamina, which is something to wrap. And this is the external elastic lamina is what we can see very clearly like a black line. Now, if you look at here on the top, they're showing a stenosis, which they have blown up, and you can see there's haziness there. And then if you go through that, you can see there's a lipid core and a plaque. The plaque is appearing hypoechoic, or this is actually infrared light. So I wouldn't say it's hypoechoic, it's just hypo-intense on this imaging. And there's a rupture in the plaque, as you can see. There's a rupture in the plaque here. Okay. Oh, I can draw things on this. Wow. Okay. And then calcium, you will see very discrete kind of structure. The light passes through the calcium. On the other hand, if there's a calcium here, like this is calcium here, you see a shadow on IVUS. So sometimes you cannot see the things behind it. While here you will discretely see calcium like this, like a structure. And the lipid, this is also lipid, as you can see, this lipid hypo intense, because this is infrared light. So it's red infrared light. So anything which is red will absorb this. So if you have blood in here, you will see a lot of shadowing. You will not see anything. So what we do is, how do we imagine this? Is we give a contrast load. So contrast cleans the blood, and then we image it so that we can see inside the stuff. Otherwise, we cannot see anything in there. Same thing with, you can see red clot. Red clot will also give you a shadow. White clot will not. Difference between red clot is what? Red clot has much more fibrin degradation products in it. White clot is mainly platelets. Which happens first? White clot, number one. Then this starts happening. So patients that present to us usually have red clot because they are late, especially in this COVID time. And this will not get dissolved by the antiplatelets as readily as the white clot does. Okay. All right, I think that's pretty much it. Do you have any questions that I can answer, or you want to learn something more?